Now, just a bit of a twist, Caitlin. Can we take the last few minutes to focus on another subset, a patient with renal failure, where we have excluded amyloidosis, and now we have basically confirmed that this renal failure is a result of multiple myeloma. Your take in this particular situation, what do you usually utilize and how do you proceed?
This is what we probably see all the time, especially working in the hospital, right? These patients come in and you want to give them the benefit of the best therapies you can from the get go. So, one of the things I see happen more often than not, which I will try and dissuade people from, using, is kind of like the old school cyborg. I think we have enough data that tells us now that cytoxin based regimens are nowhere near as good as what we know the IMIDs and the proteasome inhibitors do. But those patients really can't get a lot of IMIDs from the get go. They come in the hospital, you can't get the drug in the hospital. And so I think what I like to do for these patients is start them on the monoclonal antibody, bortezomib, and dexamethasone from the get go. And the key is that you do that urgently. Time is kidney, right? So the more time that passes, the more that kidney is getting damaged by those light chains, for example. And so if you can start those patients on at least those combinations of three drugs, perhaps when their renal function improves, you can start adding in the lenalidomide as an example at low dose, depending on where the renal function plateaus or hopefully normalizes back at the full dose you would normally do. But my approach is always to try and intervene as quickly as I can. And that DARA bortezomib dex combination is a really easy place to start, probably for all comers.
Indeed. Caitlin, we've covered a lot here. Before we close, any last thoughts for us in community settings managing the multiple myeloma patients?
Think a couple tips. One is please don't continue the Dex indefinitely. Right? We know that the never ending Dex treatment is something that our patients hate the most, and I think we can cause the most trouble with. So, there's data from our older, frailer patients that if we can start them off on Dara-Len Dex and drop the Dex just after 8 weeks, we're not going to lose that response. So don't be afraid to stop the Dex. Um, Please don't forget to send some of the biomarkers we talked about, the LDH and the beta 2. It's very helpful to understand kind of risk assessment. Don't forget your prophylaxis. These are patients, remember, who are at high risk for DVT or thromboembolic events, and certainly for HSV and VZV. So don't forget that those proteasome inhibitors and the monoclonal antibodies all need acyclovir, for example.
Couldn't agree more. Thank you so much for those tips. Those are extremely important. Caitlin, thank you so much for taking the time to go over your paradigm in treating newly diagnosed multiple myeloma. For our listeners, let us go over a quick recap.
In this ever changing space of multiple myeloma, be it new drug approvals or role of MRD, we had a chance to put this all together in this episode with Dr. Caitlin Costello, a myeloma specialist from UC San Diego.
Do we have enough data to pick one quad therapy over the other? What about a perfect maintenance strategy? Well, there are a lot of nuances to be appreciated when treating a patient with multiple myeloma. In our conversation, we have covered treatment options for both patients eligible and ineligible for transplant. Keep listening to stay updated on the latest in hematology oncology. We are your hosts, Oncology Brothers.